The topic actually is something that can be or can appear a little bit boring because hypercoagulable state means something related to coagulation that maybe I hated coagulation when I was a student, and then I spent all my life by doing research on coagulation. Let me just say these are my disclosures, sorry, and just few cartoon, not much, on coagulation, just to tell you, to remind myself that coagulation is a little bit complex. And as you can see, there's a sort of cascade of clotting factors that activate each other. And at the end of the day, is the result is the formation of a clot, of a stable clot that means that this is very important, clearly, when we have a problem of hemorrhage. But this process that is very complex, as you can see, you can activate by the extrinsic and the intrinsic pathway. You have two pathways of activation of coagulation. Is very well tuned by a system of inhibitors that mainly act in two ways. One, I think you know all about antithrombin. Antithrombin is just a protein that tend to block the activated clotting factors, mainly factor 10A and factor 2A. When you use heparin or low molecular heparin, you act by enhancing the effect of antithrombin towards the inhibition of factor 10A and factor 2A, that is thrombin. The other system is the protein C, protein S system. You may have heard about it. And what this system do is just to inactivate two cofactors, that is factor 8 and factor 5. So one system blocks the activated factors, the others block the cofactors of coagulation. And so you have a sort of very good balance. However, when you ask for a PTT, you do something very wrong in what is the real nature of coagulation, because coagulation occurs on surfaces. And when you perform this kind of test, you use only plasma. Actually, coagulation occurs in surfaces, particularly platelets, and you need platelets for coagulation to occur, as well as endothelial cells. And if you have endothelial cells, you have good inhibitory systems that can work together with this complex system of coagulation. And what you maybe, as a particularly cardiologist, know quite well is something related to the fibrinolytic system. In the past, you used a lot of thrombolytic therapy. And what is thrombolytic therapy? It's just a recombinant TPA. That is an activator of this plasminogen to plasmin that then tend to dissolve the clot by a very nice process that at the end of the day release the so-called D-dimer. When you measure D-dimer in your blood, what you do is just to see the effect of plasmin in the clot that is forming into the vessels. So this is something, this is all what I wanted to tell you about coagulation and fibrinolysis. And I think that you clearly understand that there is a very well-tuned equilibrium in our organism that is mainly this hemostatic balance. But if you have an excess of procoagulant factors or in a reduction in inhibitors, in anticoagulant factor, you unbalance this system and you can be predisposed to thrombosis. And this is what I want to tell you about hypercoagulable states and thrombophilia mainly. That is just this imbalance toward thrombosis. And thrombophilia mainly is a clinical concept because it's a propensity to the patient to develop thromboembolism or thrombosis in general due to an underlying hypercoagulable state that can be related to some genetic or acquired conditions. So you may know about that because you don't know actually if a patient with thrombosis has indeed a genetic defect that can cause that thrombosis or say acquired. What I'm dealing with? I'm dealing with patients that present with some family history of thrombosis or personal history of thrombosis. This is even worse if this occurs at young age, because you can think about the possibility to have a genetic defect and an underlying genetic defect. And then this patient tends to have a recurrent thromboembolism, and you don't know why this recurrences occur. And then sometimes you have thrombosis in really unusual sites in the brain, in cerebral vein thrombosis, or say in splanchnic district. That is not common actually. When you think thrombosis, you think something, you think to something related to, say, the legs or maybe the arms, but it's very strange to have thrombosis in this unusual site. Well, what are the causes of this thrombophilia? You have a list here. On the left-hand side, you can see the inherited condition, and on the right-hand side, the acquired condition. I think that you are familiar with some of them. Maybe the clot inhibitor deficiency, antithrombotic protein C and protein S, and maybe the common polymorphism, the factor V lady, maybe a nephrothrombin variant. Maybe you heard about this condition. But there are a number of new conditions, mainly unknown also, and that deserve attention when you deal with this kind of problems. The other thing is the word of acquired condition. I think that you may know that cancer is associated with thrombosis. There is a strong association between cancer and thrombosis, but also some other more light conditions that can predispose to thrombosis are important to mention, such as pregnancy, oral contraceptive treatment. And sometimes you heard about some patient, some young lady who is taking oral contraceptive and a pulmonary embolism or thrombosis, or sometimes they can die because of that. So it's something very, very serious to be taken into account. But as you can see, there are a number of conditions that can be associated with thrombosis that you must know. The other concept that is very important is that there must be clear to everybody that there are different types of thrombophilia. There are some light thrombophilia, some mild thrombophilia, I would say, that maybe is the heterozygous and heterozygous prothrombin variant. And why I'm saying that? Because if you don't, among us, there are someone, 1, 2, 3 in 100 that present with this mutation, and you don't know to have this mutation, and maybe you don't care to have because you'll never develop thrombosis because of this mutation. But if there is someone with a severe thrombophilia, an antithrombin deficiency, this is more severe condition, and maybe during the lifespan you can develop thrombosis much easier than with a mild condition. And then there is the big chapter. Maybe you heard about the antiphospholipid antibodies syndrome that are quite highly considered in terms of the risk of thrombosis, either arterial or venous thromboembolism. So you have to face with all this kind of thrombophilia. Why this is important to know? Because as you can see, these are data that come from a review from Campello, one of my co-workers. You have to know that the risk related to each of these conditions is a little bit different, depending on the condition that is present in the patient. So not all thrombophilia is the same. But what we do in general is consider thrombophilia as the same thing, regardless of the type of thrombophilia is present in that particular patient. So this is something that sometimes makes you in trouble because you have a bad estimation of the real risk of the thrombosis in these patients. So who are these patients? These patients are, as I told you, young patients mainly with strong family history of venous thromboembolism with recurrent thrombosis or thrombosis in unusual site. But why we need to know about thrombophilia? We need to know about this hypercoagulable state in the patient. Mainly, the first thing I can say as a clinician is that the patient wants to know why he has developed thrombosis. And so this is important to know and to tell the patient, well, the thrombosis may be related to an antithrombin, a protein C deficiency, rather than to say, yes, it has occurred thrombosis, but we don't know why exactly. Also, this is very important to know because sometimes this thrombosis, as I told you, can be related to cancer and to other conditions. So just to say that thrombophilia is the reason why the thrombosis occurred can be relevant. But then it could be related to the influence of the treatment. Particularly cardiologists could be interested in that. Do I have to do something different in a patient with, say, antithrombin deficiency as compared to a patient without when I treated an acute thrombotic event? And the answer is absolutely not. Maybe there is no reason why. There are some very particular, peculiar exceptions, but the majority of patients can be treated without having this kind of information in the acute phase of the disease. What is the relevant? Indeed, is the problem related to what is happening after the acute phase, and particularly the recurrence risk. Does thrombophilia impact on the risk of recurrences in patients who already have a thrombotic event? And indeed, this is a big problem because there was a big debate in the literature about the real risk of recurrent thrombosis in the thrombophilic patient. I want to give you the idea of what I do every day almost in my outpatient office when I have a patient with thrombosis. And when someone asks me what is the importance of factor V bleeding, I'm an heterozygous factor V bleeding in terms of the risk of thrombophilia. Well, as you can see here, is one of the factors that you have to consider because the patient can have factor V bleeding, but then can be obese or is older, and then a trauma or a surgery can occur. So the real final risk for this patient to have a recurrent event depends on many factors, not only on thrombophilia. So you have to be clear, it must be clear to you that when you have a patient, a thrombophilic patient, this is not enough to establish what is the real risk for recurrences in this patient. So I think that this must be taken into account in our daily practice. This is so important that the International Society of Thrombosis and Hemostasis, and particularly the ASH, the American Society of Hematology, presented with a huge work in trying to understand what is the real role of thrombophilia in patients who had already had thrombosis. And what is the importance to know about thrombophilia in asymptomatic patients? Maybe some of the family members of a patient with thrombosis are carriers of thrombophilia, but they don't know. So it's important to study this thrombophilic condition, this patient, in order to prevent thrombosis. And this is what they try to address. I want to just focus on some very, can I say, general stuff that is mainly related to what I will do in a patient with, say, a non-surgical major transit risk factor who has developed a DVT, or after a DVT because of pregnancy, or a DVT after oral contraceptive. What I would do is just to treat this patient for 3 months with oral anticoagulants. But if you have thrombophilia, this can change completely the view of this patient. It can tell you need to prolong the treatment because of higher risk of recurrences because of thrombophilia. So knowing the presence or absence of this defect can change your clinical practice in terms of prevention of the secondary prevention of venous thromboembolism. Another very important point comes from some data also from my group that when you are treating a patient with oral anticoagulants, this patient is exposed to bleeding. And so the problem that you have is important to continue the anticoagulation in order to prevent a recurrence of thrombosis, or you are scared about the possibility that a patient develop a severe bleeding and can die because of this bleeding, say a brain, a cellular bleeding. So this is an important point. Well, patients with thrombophilia during oral anticoagulants tend to have less bleeding than patients who are not thrombophilic. So this is reassuring a little bit in treating longer this patient with our anticoagulants. The other interesting point related to thrombophilia and treatment of thrombosis, the treatment with DOACs. DOACs, the direct oral anticoagulant, the drug that you are using every day in your clinical practice. Well, if you treat this patient with warfarin or with DOACs, the result is that after stopping the treatment, those thrombophilic patients who have been treated with DOAC tend to recur less than patients who have been treated with warfarin. That for us, from the clinical point of view, push us a little bit more in treating this patient with DOACs other than with the warfarin. The other few points that I want to tell you about the primary prevention. So no thrombosis has occurred yet. And you want to know if thrombophilia is relevant in order to prevent the first thrombotic event in the patient. And this is actually relevant particularly for the clot inhibitor deficiency. So if you have family members of a patient with thrombosis in which you have identified, say, an antithrombin defect, it's important to study the family members, the asymptomatic family members, because the benefit of this information in terms of saving the first thrombotic event is absolutely more important than the risk that you expose the patient by giving prophylaxis during, say, a risk period for thrombosis, say surgery, or you prevent oral contraceptive administration. So this can be important. Look, this is what deal with women. A very important thing concerning oral contraceptive or hormonal replacement therapy. Again, you can see that maybe if you have fatal fibrillation or prothrombin mutation, is not such relevant in terms of the event that you can prevent after knowing the presence of thrombophilia. However, for the clot inhibitor deficiency, the number of events that you can prevent by avoiding giving the combined oral contraceptive is really relevant, and say that some of these events can be also crucial or fatal. The same is true of pregnancy. You manage a pregnancy differently according to the type of thrombophilia that you have. Say fatal fibrillation and a prothrombin mutation do not need any prophylaxis during gestation. But if you have antithrombin deficiency, you need to administer prophylaxis during gestation. So this is an information that you as cardiologists could, I know that you're not all cardiologists, but I think that this is a common information that can be important for all kind of physicians that deal with this kind of problem of thrombosis. Something that you could know is the fact that about cancer. Cancer is clearly, I don't have to tell you that cancer is associated to thrombosis. You know quite well through teach it us about that. But the point is that we have the feeling that there are cancers that are more associated to thrombosis than other cancer. Pancreatic cancer is dramatically associated to thrombosis. Maybe breast cancer is much less associated with thrombosis. So if you have to decide to administer prophylaxis in the type, depending on the type of cancer, I think that you would say, I give prophylaxis to the pancreatic cancer and not to the breast cancer. However, the data that we have is dramatically interesting because if you have thrombophilia in patients with low risk cancer or intermediate risk cancer for thrombosis, you can increase the level of risk of this patient, even though the basic cancer, the cancer has a lower probability to develop thrombosis. So knowing thrombophilia in this cohort of patients at low risk for thrombosis, because the cancer in itself is associated with a low risk of thrombosis, allow you to decide to perform prophylaxis in this sense. And the data, the meta-analysis data that we have in our hand clearly show this fact that just the presence of fatal fibrillation or the prothrombin mutation, so the low risk thrombophilia we are dealing with this kind of defect tend to increase the risk for thrombosis. So another interesting part of the story related to children, if you have children with thrombosis, please perform the thrombophilic screening, because the lower the age, the higher the probability that a thrombosis, if it's not explained but a severely ill, because severely ill children can have thrombosis if they have catheter, if they are in ICU, if you are dramatically ill. This can predispose to thrombosis. However, we have children without this kind of situation, and if they develop thrombosis, it's very likely that they have a thrombophilic condition. Let me just go. I have some 5 minutes more, or 5 or 10 minutes, not more. It's something that I like very much, because all this information that I gave you related to an old story, they deal mainly with, as I told you many times, clot inhibitor deficiency, common polymorphisms such as factor V and prothrombin variant. These are conditions that were discovered in the last cycle. So it's funny that there are no other thrombophilic condition discovered after that. And the point is that the information is a little bit polluted by the fact that all the study concentrates on that kind of condition, not on other conditions that maybe are relevant. Professor Basson before mentioned this discovery of the factor IX Padua. Why this discovery is relevant? Because it was the first time that it was found something very strange. This guy, this young boy, presented with an activity of factor IX, or more or less 800%, 8 times higher as compared to the wild type factor IX. And the antigen, the amount of protein was normal. So normal protein, but very high level of activity of this factor. And this was due to a mutation, a single point mutation that is just a single amino acid substitution that changed completely the activity of this molecule and make it hyperfunctional. So the story is very simple. It was related to thrombosis, a severe thrombophilia in a young boy, 22 years young boy. What was interesting in that, and the fact that it became very important around the world, that the possibility to use this mutant, this variant in the gene therapy was so important that was a game changer in the gene therapy of hemophilia, because you could use a lower amount of vector. I don't know, some of you maybe are interested in gene therapy in many fields. The problem of having a high level of vector tend to be not so good, because this can cause hepatitis, this can cause a lot of problems. So the idea to reduce the amount of vector that you inject to perform gene therapy was very successful. And the fact that you have a molecule that was expressed at a low level but have a high function allow you to have in blood enough factor IX function that correct the hemophilia B patient. These are one of the first clinical study published. As you can see that you have an increase of factor IX from almost zero, such as you find severe hemophilia B patient, to 30 to 40%. That means you cure the patient clearly from hemophilia. And this is because factor IX Padua was present in the preparation. And these are the data after 6 years. You can see that these patients have been treated and are effectively cured from the hemophilia A. There are many other conditions. I go very fast on this, because this is just to tell you that there are many other things in addition to what was studied in the last cycle. And this is an hyperfunctional factor IX that is similar to factor IX Padua, but with a lower hyperactivity. And these are mutations in the prothrombin gene. And the prothrombin gene, these are very interesting, because I told you that antithrombin block the active enzyme, so it blocks thrombin. But this prothrombin, that is the precursor of thrombin, is modified in a way that antithrombin is not able to block the function of thrombin. So it's like to have a defect of antithrombin, but in this case, antithrombin is present, but cannot block the thrombin that is formed. And it's very interesting because we also had problem when we deal with this patient at the beginning, because when you perform a PTT or you measure the activity of the antigen of this molecule, you find a reduction of the prothrombin, meaning that the reduction of prothrombin should be something related to bleeding. And in fact, it was not. It was exactly the opposite, because the defect that mirror a bleeding defect actually was associated with severe thrombosis. In fact, we gave the contraceptive treatment to one of these two to the proband, and the patient was admitted to hospital with a severe, even almost deadly pulmonary embolism, because we didn't know about the fact that of the existence of this defect, that after that we could identify. And there are many of these defects around the world. Factor VIII is another very important molecule. If you have increased factor VIII in Cushing syndrome, you see you have high factor VIII and you have thrombosis. Factor VIII is an acute phase reactant, and you can find factor VIII when you have infection, for instance. But this is the first demonstration of a genetic defect that is related to an increased level of factor VIII. We described this a few years ago, and this was the first real demonstration of the presence of a gene defect. What is interesting also on that is that this was related to something that generally destroys a gene, a large duplication. In your field of interest, if you have large duplication in a gene, generally you destroy the function of the gene. In this case, actually, you have a 25 kilobase duplication of the factor VIII gene, and actually you have a gene that was hyperexpressed, because maybe you have two promoters that push the synthesis of this factor. So it's something strange. And this is very recently, few months ago, another defect that is related to the factor VIII. This is the second gene mutation that have been identified as responsible of high factor VIII levels and the thrombosis. So what I want to say that there are a number of new mutations that we don't know and that we have to face with that we need to know when we deal with the thrombosis, particularly hypercoagulable state or thrombophilia. I want to show this last case that is very funny for me, because this is an antithrombin defect. And if you measure the antithrombin activity in our lab, you find a perfectly normal antithrombin activity. So you gave this patient oral contraceptive, and you say you can have, say, normal pregnancy, you don't need to do anything. And indeed, this is a severe antithrombin defect that you cannot catch with the usual antithrombin test that you perform, even though this patient can have, say, family members with thrombosis. You perform the screening, the coagulation screening, and you have a problem to identify this patient. So how to manage all this story? I want to conclude by saying that we have a different approach now. Since now we try to perform the screening of thrombophilia by performing all these tests. Maybe some of you saw the results of our screening test that we perform here in Padua, with a number of conditions that we have testing. Indeed, you can see that even though you perform so many tests, you don't have actually the possibility to identify all the defects that I mentioned just a minute before. So we need a completely different approach. And so we decided to use the next generation sequencing. Everybody now uses next generation sequencing, and you have a huge amount of information coming from the sequencing of a big number of genes for each patient. And so how to use this information that, however, is too much to try to, can I say, apply every day for the single particular patient. I want to tell you what we have done in another in another patient. We studied 33 relevant coagulation genes of the protein that I show you in the cartoon at the beginning of my presentation. And the patient were, I don't want to go through the type of patient that I want to show you what we have found. We have found that according to the classification of the variant that can have an impact on the function of the gene, you can think this in all your field of research, actually, you can find a number of these genes that presented with mutation that can impair the function of that particular molecule. At the end of the day, how can you put together all this information? You need a global test, and actually we perform a global test, and the global test is not just the test that I show you before, in which you can have actually the normal level of the factor, but we tend to use now some global assay. Maybe you heard about the thrombin generation. Thrombin generation is a global test that tell you how the patient is able to form thrombin. And so what we do, we perform the analysis, the clinical stuff, and then we perform the conventional thrombophilia testing. And if the test is negative, we perform a global test to see if there is an increased thrombin generation. If the result of all this mutation that can be present in the patient determine an increased level of thrombin generation. If there is actually a positive increased thrombin generation, we perform NGS. And according to NGS, we are able to identify the pathogenic variant that can be then responsible for the clinical finding of that particular patient. So it's a completely different approach, little bit complex, but we are sure that maybe with the help of the AI, you will be able to automatize also part, at least, of the interpretation of this difficult pathway to identify, to clarify what is really a hypercoagulable state. So in conclusion, I think the hypercoagulable states are clinically relevant. And I mean, you may know, maybe you have a sort of flavor now of what can be behind this kind of problem of hypercoagulable state. Thrombophilia testing is useful, clearly can influence the management of the patient. The answer is clearly yes, but still we have a limitation in the panel of tests that we perform daily. So we need to focus a little bit more on these emerging tools, particularly the NGS, and in particular the flow chart that we have to use in this particular type of patient. The future, as I write here, maybe lies in the personalized integrated approach that combine genetics, phenotype, and clinical context. A very complex task, but I think that we have the effort to face it, and these are my co-workers that clearly are deeply involved, a little bit more than the one you mentioned, but we have grown up in time. And I would like to thank you very much for your attention.